Thank you for joining us for tonight's educational webinar, Bunions, Flat Feet, and Heel Pain. Tonight's speaker is Dr. Nick Cheney, OrthoNeuro's orthopedic foot and ankle surgeon. Dr. Cheney is a board-certified orthopedic surgeon who specializes in foot and ankle surgery. His practice emphasis includes ankle arthroplasty, heel pain, bunions, hammer toes, and fractures, as well as foot and ankle sports injuries. Dr. Cheney will answer questions following his presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Cheney?
All right, thank you very much, Heather. Let me see if I get the PowerPoint going here. All right, so I hope everybody can see this. Thanks for joining us tonight. The weather was beautiful today, and I missed most of it in the operating room. So if anybody wants to tell me about it later, that'd be appreciated. So we're going to talk about bunions, flat feet, plantar fasciitis, something I see all the time in my office, and we'll kind of get into detail. So my background, I'm an Ohio guy. I was born and raised in Lima, grew up there, went to school. I started at the University of Texas. I swam in college, went down there and learned a few things, and then transferred back. I was homesick, came back home and finished my undergrad education there. And I went to medical school here in Ohio at Ohio University. I did my internship residency here in Columbus through Doctors Grant and Children's. And then I went up to Grand Rapids, Michigan, not the Ann Arbor, Michigan, the Grand Rapids West Side, where it was heavy with Notre Dame and Michigan State fans, and did my fellowship, a year-long specialty training in foot and ankle surgery. So, interestingly enough, this is where I learned this philosophy. So there's kind of two philosophies when it comes to orthopedic foot and ankle surgery. And I've been fortunate to kind of see both sides of that coin. When I was a resident, I trained with some very good guys here in town who taught me very well in one philosophy. And then they recommended I go check out Grand Rapids. And so I went up there and learned a different philosophy. So I feel like I've got a kind of unique take on foot and ankle problems. So we're going to talk about, how patients develop these conditions, how are they treated both non-operatively, and then ultimately if people fail conservative care surgically. And then if you can believe it or not, I'm going to show you how they're all related, and they're all kind of due to the same problem. So let's see what we got here. So bunions, what are they? Everybody's, I imagine probably some of the people on here have this problem here. So what are they? Painful bump on the inside of the big toe. You have a problem wearing shoes, so you're having to continue to buy a wider and wider shoe, a soft shoe in the toe box, and a big toe then pushes into the second toe, so you can get some corns or calluses between your toes. And obviously, I would imagine some folks on this webinar tonight have this problem. So why do patients get them? Shoe wear is a common theme that is kind of something that patients come and say, oh, I've worn terrible shoes my whole life. Well, they've actually done some studies, and it doesn't necessarily correlate with the type of shoe you wear. So that, that old high heel and that narrow toe shoe doesn't necessarily create it for the reason that you think. And so I'll address that later. I think it does have to do with the shoe wear, but not in the way that most people think. Genetics. I think genetics do play a part in this, but that's not the vast majority of the bunions that I see. There are some young folks that have these, and I think they're born with this problem. It may not be painful. So if it's not painful, you don't do anything about it, but genetics can play a part. Karma, is it bad luck? Did you do something wrong? Did you get it for that reason? So bunions actually develop as an arch collapse. So if you look, see if my pointer works here. So the foot is an arch, right? And so as I like to describe to patients in the office, the arch, an arch design is designed to support a compressive load. And so this foot is holding our entire body weight. And so if you look at this diagram here, it's a nice diagram I found, where in reality, the weight should be distributed on the foot evenly. Half the weight on the front of the foot, half the weight on the back of the foot, on the heel. And so you've got your tension side and your compression side. And if you notice, the ankle is not over the center of the arch here. And so if anybody has looked at knows anything about arches, you've got your keystone, kind of that central piece that everything's built off of. That's supposed to be the most stable. It's not supposed to move. And so this is kind of where that is in your arch. But if you look at where the ankle sits, it doesn't sit over the center of that. And so if the weight's not distributed appropriately, it'll cause things to start to break down. So here's another example where you got half the weight here, half the weight here. And then, when we look at a different picture, you'll kind of see how the weight is distributed on the ball of the foot and how it kind of causes this stuff to break down. And so what causes that imbalance of weight in the arch to fail? And it's due to an overload to the front of the foot from a tight calf muscle. So if you look here at this diagram, you've got the two muscles, the gastrocnemius and the soleus. And those two tendons merge right about there to make your Achilles tendon that attaches on the back of your heel bone. And so if you look at this picture, and I love this picture because it does show the anatomy very nicely. This is your soleus muscle right here, that little sliver, okay? This big one right here is your gastrocnemius. And if you notice, it inserts on the back of the thigh bone. This is your knee joint right here and your ankle joint down here. And so it crosses both the knee and the ankle. And the soleus muscle starts in the back of the leg bone here. So it only crosses the ankle joint. And so what happens is this contracts for reasons yet to be disclosed or identified, but it becomes shorter than this muscle, the soleus muscle. And so what it does is it increases force to the front of the foot. And we'll kind of go through this a little bit. And so how does it cause this? How does this cause a bunion? Well, the tight calf, so plantar flexion means that, you know, your toes are pointing down. It causes a little extra weight to go through the front of the foot. And so then it affects one of the joints near your big toe, and it becomes kind of loose and unstable. And it causes the arch to start to fail in a very predictable fashion. And so that first toe bone starts to drift and rotate. It doesn't become a growth. It starts to drift and rotate. And so if you look at this foot diagram here, if you notice the size of this first metatarsal bone, so the weight on the ball of the foot goes through these bones right here, these metatarsal bones. Your toes here, they're more for, you know, gripping the ground, a little bit of balance, but this is where the weight goes through these bones right here. And so if you think about a teeter-totter, you know, let me back up. So this bone is bigger than the others. And the reason is because it takes half the weight on the front of the foot. The other 4 divide up the other 50%. So this bone is very important, and it was made bigger for a reason. And so if you look at a teeter-totter, you know, if the ground's pushing up here, it's levering down here, that joint wants to start moving a lot more. And so the interesting thing, if you look at that joint, there is no inherent stability there. It's all strong capsule, joint capsule and tissues that hold that joint together. And over time, that can break down if the weight's not distributed evenly. So how do you decide if you have a tight calf muscle? So this is called a silver skull test. This was Dr. Bohe, who trained me in Grand Rapids. And this is an example of how you do this test. And so you have to hold the foot in a certain position to isolate the ankle joint so that you're getting motion just through the ankle. And so when we do this, if you look with the knee straight, the toes are pointing down. If you look at the blue arrows, and when he bends the knee and he relaxes that calf muscle, remember the gastroc starts above that knee joint. So when you bend the knee, you relax it. Then you're checking that other muscle, the soleus. And if you see how far the foot comes up, I didn't measure that because this isn't exact science, but you know, there's a fairly big difference in the angle of that foot. And so that's what causes that little overload to the front of the foot. And so we actually did a study we published last year looking at the proper and improper ways to do this and how you can miss the tightness of the calf if you don't do it the right way. This is a picture of my daughter when she was 4. She's now 11. And if you look at that angle, it's pretty similar. So young kids, and I have a theory why young kids are much more flexible than adults as we get older. But if you look at the angle, it's pretty similar with the knee straight and the knee bent. So she does not have a tightness in the calf. A bunion, so what do I look at on an x-ray? So I look at this, right? So this bone is still straight. It did not grow crooked. And these little bones didn't move, right? And so what we look at is we look to see if this bone has drifted out and the angle between this bone and the second one, and it's wide. And because this joint has gotten tired, the bone has drifted and rotated internally here. And so you get that prominence there, which is just this bone that's moved in. And in reality, these little bones right here sit underneath this first metatarsal bone, and they haven't moved. They stayed right where they're supposed to be. And so this big toe bone has actually drifted out and rotated over. And so when this toe goes in, this other toe has to go out compensatorily. And so that's why you get the bunion deformity. So again, important, it's not a growth, right? You didn't grow something, the bone didn't grow crooked. That toe bone drifted out. So how do we treat them? There's not a lot of conservative options. Again, for me, it's part of an arch collapse. So I tell patients, you know, stretch your calf, accommodate it with shoes as best you can. You know, orthotics are an option, but they don't fix the deformity. They don't prevent the progression. unless you're treating what the root cause is, and that's that overload to the front of the foot. There's a lot of products out there that are on the market that insurance doesn't pay for a reason, because there's no data that says that they work. And so you can do, and I will use these. I'll recommend toe spacers and some bunion straps to try to just give some pain relief, just to see if it helps to try to augment the stretching and the shoe changes. But really, when do you have it fixed? When your quality of life is negatively affected. This is a quality of life problem. I tell patients all the time, when your good days are more than your bad, don't have it fixed. I told somebody here just a few minutes ago, same thing. If it doesn't bother you that much, don't go through the surgery. It's not cancer, it's not heart disease. I chose orthopedics because I didn't want to deal with life and death. I wanted to try to improve lifestyle and quality of life, not life or death. And if you can live with it, I tell patients don't have it fixed. And probably 75% of the patients I see that come in for this, I talk them out of surgery because it doesn't bother them that bad. Their biggest concern is, will it get worse if I don't fix it? So it's a pain issue. No matter how bad it gets, it can always be fixed. So I wouldn't rush into surgery. So how do we fix them? So you failed conservative care. You tell me I can't live with this any longer. It's, I can't do this. So how do you fix it? Well, there's about 150 different ways to fix a bunion. There's many ways to skin a cat. Not everything is right. Not everything is wrong. But there's really only about 2 options that I know of that you can predictably correct a bunion and more than likely prevent it from coming back. And so we're going to talk about one of those tonight. All right. So again, the bone didn't grow crooked. So if you look, this is one of the times where they cut the bone and they made the bone crooked to try and correct this. And the problem with that is the literature shows, our science does show that there's a very high recurrence rate with that procedure. And so it doesn't address where we believe the problem to develop from. And so that it doesn't change the fact that it can continue to progress and recur. So how do I fix it? So again, I think this joint is too loose, right? So I come in and I realign it and I bring this bone back over where it's supposed to, and you notice these little bones are lined up right underneath there where they should be. And the angle between these 2 bones is back to where it should be. And we try to get this to grow together. And actually, we just submitted this paper for publication where we looked at the recurrence rate with this. And so we had a relatively small study, maybe 40 patients, but when everything healed, the recurrence rate was 0. And about a 96% healing rate is what we found. And so, if everything heals, you should be good. Again, it's not a 10-year follow-up study. It's a 10, 11, 12 months follow-up study, but the recurrence rate was almost 0. So and that's what we're looking for. So people worry, well, you fuse that together, does it affect my ability to run or walk? Well, these joints, if you remember that first picture, this is that keystone of the arch. These joints aren't supposed to move. And so when that joint gets too tired and wiggles too much, that affects the rest of the arch. So weight starts to shift to places it shouldn't be, and it causes other problems in addition to the bunion. And so by fusing this, we're not losing anything. By fusing it to the next one, we're not losing anything. We're reconstructing that keystone and restabilizing the arch. And so I take care of the OU athletes, and I've done this operation multiple times, and they're all functioning at high levels amongst other folks. So, the anatomy textbook would tell you 1 to 1.5 degrees of motion. When I take the foot on the exam and I shuck it up and down, and I tell the residents and the students that are on with me all the time, look at this. The anatomy textbook says 1 to 1.5 degrees, and it's always multiples of that. So it doesn't affect it. So here's like a before, and here's an after. And so ideally things stay where it heals, it stays where it is, and it should not, in theory, recur. Now we're on to flat feet. All right, so I'm gonna imagine a couple people know what this looks like. So the arch has failed. So this is a more progressive collapse than the bunion. The bunion is kind of an early arch collapse problem. And then the flat foot is when things have progressed even further. So it's kind of worked its way back into the back of the foot. And now you've got something else failing. So the heel tilts out. So if you draw a straight line down, that heel is kind of tilted out. We call it we call that valgus. And you can kind of see how the inside of the arch is now draped on the floor. You can get pain on the inside. You can get pain on the outside. You can get pain in the front of the foot from other problems due to the arch collapse. But if we're looking at just a flat foot, we're usually worried about pain here or pain over here. All right. All right, so why do patients get these? Well, I'm sure you guys probably have guessed it by now. Genetics. Now, I would stop here. I see a lot of not a lot, but I see pediatric patients that'll come in. Mom, dad, grandma, grandpa. Somebody's concerned about the child's flat foot. A flat foot can be a normal architecture for a patient. It only becomes a problem if it's painful. And so the flat feet we typically talk about that are painful are stuff that develops over time because of this collapse that we're talking about. And so just because you have a flat foot, if it's not painful, doesn't mean you need an orthotic. All right. So I see a lot of people that come in and say, oh, I got an orthotic because I was told I need it. You only need it if you're having pain. And so you may have been born with flat feet. My son, I've got a high arch. My son has a flat foot like a pancake, but I'm not going to do anything about it because he's not painful. So improper shoe wear, again, I think there's an issue, and I'll kind of get into that maybe later with shoe wear, but not for the reason people think. Being overweight, again, it's not a weight problem. It's how the weight is distributed on the foot, as I tell people. If the weight was balanced on the foot, it wouldn't matter how much you weighed. It's more about how the weight is loaded onto the foot. All right, tight calf, right? So this is your posterior tibial tendon. It comes down and attaches on this bone called the navicular, and it pulls that arch up. And so what happens, sorry, what happens is you're overloading the front of the foot. That arch is starting to sag, and your big, strong Achilles, your gastrocnemius and your soleus are pushing this front of the foot into the ground. And this little tendon is trying to pull up against it. And so it starts to lose that battle. And so it can also be known as posterior tibial tendon insufficiency. If you look here, so this is just kind of one of the foot models that we have. This is kind of a neutral arch. You see this line, this is called Murray's angle. It's running straight down here. If you overload the front of the foot, look what happens. It starts to sag and break down. And so this is what happens over time. It's very, very subtle, but it does happen over time. And you kind of see how that arch starts to fail. And so, what do we look for in exam? A tight calf first and foremost. Number two, where it hurts. So this picture here shows what we call subfibular impingement. As that arch starts to fail, your heel bone can actually pinch into the fibula bone on the outside. You can get some pain there depending on the severity. And then obviously where that tendon inserts on the navicular, like we showed over there. We want to know, can you get up on your tiptoes? So that arch tendon helps you get up on your tippy toes. And if you can't do that, a lot of times it tells us that tendon is not working. And obviously, I want to check the front of the foot. Is that big toe joint loose? And interestingly enough, I did a study a couple of years ago where I looked at the incidence of bunions with flat feet. And so again, the front of the foot has to be failing, in my opinion, before the tendon can fail. And so it did show a direct linear correlation. People have looked at things in the past. Do people with bunions have flat feet? And they didn't find that, but they didn't look to the next step. And so I believe this to be the case. So yeah, if you look here, here's a flat foot. If you look, you remember that line I had on that model. If you draw a straight line down this bone, it exits somewhere down here, instead of in line with this. And same thing here. This is your ankle bone, and that should be pointing in line with this metatarsal bone. And so if you draw a straight line down this, it exits somewhere in here. So here's a normal foot. So if you draw a straight line down here, right, nice and lined up. And if you draw a straight line down here, pretty much down the middle of that metatarsal bone. Again, another picture of the sag, right? So straight line and then the sag and cause it to fail. All right, so how do we treat this? All right, calf stretches first and foremost, because I believe that's the root cause. Orthotics. And so this is a nice diagram here. So if you look, this person has that, what we call the valgus foot, where the heel tilts out. And so we want to add a little posting to try to kick the heel in this way. So we build up the insert over here to try to kick your heel in to try to straighten things up. Prop up the inside of the arch to try to help take some tension off that tendon so it doesn't have to work as much. Physical therapy, therapy is designed to try and strengthen other muscles to accommodate. It doesn't fix the problem, but it does try to augment and help. Rest in a boot. So for me, that's number one. So depending on the severity of symptoms, if somebody's extremely symptomatic, if they, if they can barely walk, that's my first go-to. Is I'll put them in an orthotic, temporary orthotic. So it's not a $500 custom pair, something temporary that I'm able to add my widgets to try to help, do the things I want to do. in a temporary fashion, and then put them in a boot and try to rest it. As I tell patients, if things are going to get better, they're usually going to get better with rest. And it's really hard in this day and age to get people to slow down. And so the advantage of doing the insert in a boot is you can still get up and move around and walk, but it immobilizes things. You don't have to use the same muscles to the same extent. The arch support's trying to help prop up the arch. You're using the boot to try to mobilize the ankle ligaments or the tendons. And so we're just trying to let things calm down. And so that's really for the more significant cases when they first present. The calf stretches, somebody comes with a little bit of discomfort, no severe collapse, anything like that. We start out with stretches, maybe augment with some orthotics. And then typically when I do therapy is if I've rested them in a boot. So I'll see them back in a couple weeks with the inserts or without, depending on the severity. And if they're getting better, sometimes we leave them in the boot a little bit longer. If they say, hey, I'm 50% better, I still think I'm getting better, we'll leave them in the boot longer and let them rest more. Try to get the maximal benefit out of rest. If they come back and say, I'm 100% better, I feel great, we try to get them out and get them into therapy. If you spend any time in a boot whatsoever, it's a cruel trick nature plays that you can spend 2 weeks in a boot and it'll take you 4 weeks to get your strength back. And so, the reason we do therapy is to try to get that strength back in a controlled fashion without flaring up the same problem you came in with. So if conservative treatment fails, right? So we do all this stuff, we exhaust all of it, then you either live with it or you got to have surgery. And so, how do we fix this? So again, for me, the arch has failed. And so interestingly, I just gave a talk about this about 6 months ago, and I'm giving another one in a month or two about, what happens when we fix these flat feet. And so, the talk was about when a flat foot surgery fails. And, the gist of my talk is if you don't address everything that's associated with that collapse and that failure, it's likely to fail after the surgery. And so for me, the root cause is the tight calf. So that's the first thing we do is a little surgery to stretch the calf. We move the heel bone back underneath the ankle as best we can. And then we want to stabilize that big toe joint so it can't sag and move up. And then a lot of times if the tendon is bad, you can't clean up the tendon, so to speak. If the tendon's bad, it's a pain generator. We typically take it out and we borrow one of the other tendons from your lesser toes to give you that new arch tendon. And so if we don't correct the things that cause that tendon to fail, that new tendon that we gave you is likely to fail as well. And so then you start running out of good options. And so it was interesting, giving that talk in the feedback. So here's how we fix one, right? So I slid the heel bone. So these two screws hold the heel bone that I slid over. This is how I stabilize the big toe, just like a bunion, right? So I want to fuse that joint so that when the patient stands, they can support the weight that they're designed to. Remember the 50%. If that joint's too loose, it can't support that 50%, and the weight starts to shift over and it elevates, and the arch starts to fail. So we want to give them that stable base to stand on. And then here's the drill tunnel where we pass that new tendon through and sew it back on itself so that new arch tendon is functioning just like the original. What's the recovery? Well, it's a bigger surgery, and in full disclosure, that's not the only option. Depending on the severity of the flat foot, sometimes we have to actually fuse some joints together to correct the deformity. So sometimes you have to fuse this joint called the talonavicular joint. And I actually, on footeducation.com for the American Orthopedic Foot and Ankle Society, I think I wrote the article on this, and I described it as the ice cream falling off the ice cream cone. And that's what happens when that arch tendon fails, is this bone starts to drift in, this one drifts over. And so we have to put that ice cream back on the ice cream cone and fix it there so it doesn't move again. And then we also have to fuse that joint because, as you saw on this picture, hold on, this bone starts to tilt out. So we have to bring it back underneath and fuse it in the right spot. So, but I still end up doing this to try and protect that because we've now altered the mechanics, we've taken away some motion, and we then have to try to protect the other joints. So anybody that's had any spine problems, if you have a spine fusion, most commonly the joints that wear out next, they become a problem with the joints next to where they were fused. So we're trying to do the same thing here and protect those other joints. What's the recovery? Well, it's long, right? So if I fuse bones, it's a little bit longer than if I just cut bones and try to shift them over. But typically it's the surgery that I showed there is about 2 months off the foot. because it takes some time for those bones to grow together. So if you cut a bone and shift it, it's usually shorter. Just like when you break a bone, and if you have surgery or you don't have to have surgery, it's about 6 months or 6 weeks for that fracture to heal, typically. If we're trying to fuse bones together, it takes a little bit longer. We're trying to take two bones that were designed to be separate and force them to grow together. So it takes a little bit longer. So it's 2 months pretty much off the foot. Now with bunions, it's a little bit different. The guys I trained with, we've done some studies where we've shown it's a little bit safer depending on what other procedures we do with the bunion correction. You could put some weight on your heel at 2, 3, 4 weeks, and it hasn't shown to be detrimental to the outcomes. But when I was training with those guys, this is what I did. And so when I do any of these big flat foot reconstructions, I still go with this, because the worst thing we can do is get aggressive, do too much, and things fall apart. So it's 2 months off the foot. The third month, we start a progression of weight bearing per a protocol that I have. And then at 3 months, if everything looks good, the patient feels pretty good, we get them into a shoe and have them start therapy. Total recovery time for any foot or ankle surgery, whether it be a bunion, a flat foot reconstruction, anything that's involving the bones, it can be a full year recovery. Now, it doesn't mean that you suffer for a year, but depending on the procedure, I tell most patients with this bony procedures that it takes 4 to 6 months before you kind of look back and say, I'm finally glad I did this. It's not short, which is, again, talking about the bunions. If it's not that problematic, I don't recommend having it because it's not worth the risk associated with it if you can still do the things you want to do. And I like to describe a bell curve. And so everybody remembers in school, there's a bell curve, where the vast majority of the people fall in this bell curve. Somewhere in that 4 to 6 month range, you make your biggest gains after the surgery. And you look back, you said, man, I'm not having the pain I had before. I'm not great, but I'm not what I used to be. And it's typically just a kind of a slow speed progression after that. So, and not everybody falls in that bell curve. Some people are early, some people are longer, but that's where it lies. And you kind of hit a new baseline, your new you at about a year. Plantar fasciitis. All right, this is my favorite. All right, this is the easiest thing to treat, the most fun to treat. So pain on the bottom of the heel, commonly called heel spurs. This is not a heel spur. All right. You may see a heel spur, but that's not causing your pain. Again, it's due to the arch trying to fail. And this is the very beginning of an arch failure. Again, the tight calf overloads the front of the foot and it causes stretch on that plantar fascia. All right. Plantar fascia thick ligament on the bottom, it attaches the ball of the foot to the heel and it prevents the arch from getting longer and falling. And I can tell you right now, this Achilles and the weight on the front of the foot's a lot stronger than this ligament. And so what happens is that ligament starts to get stretched and it causes pain as you're overloading the front of the foot. Now, the heel spur for me develops either from calcifications in the ligament from inflammation, or it's from chronic overload and that ligament's being pulled away from the heel as the arch is failing. The heel spur itself is not a pain generator. I have never once taken one off, and I will never take one off because the surgery to do that is way worse than what we do with this. So again, here's a nice little diagram. So you've got your keystone here, the center of your arch. You got your Achilles here and your calf muscles up there. So it overloads the front of the foot. The ground's pushing up here. It's pushing down here at that joint. The joint starts to get tired and the toe's able to elevate. And so the foot's trying to get longer. And so as it does that, it's stretching on that plantar fascia where it attaches on the inside of the bottom of the heel. And that's where people get their pain. So how do we treat this? Again, the first thing I do is a stretching regimen. So something like this multiple times a day, and people really feel it in the calf there. And that's really what we're trying to address. Physical therapy, sometimes I'll put people in a boot to try to rest it if it's really sore. Physical therapy, they can try to stretch out a little bit more and help. Injections, again, they don't fix the problem. I call it a Band-Aid. If somebody's miserable, they've got a trip coming up, they're going to Disney, we'll give them a shot and see if we can get them some pain relief for that trip. And the other thing I do is I only will give 2 injections lifetime. And the reason is when you inject down here where that plantar fascia attaches, this heel pad down here is a very special structure. And if you get multiple injections down there and that steroid causes that heel pad to atrophy or kind of shrivel away, you can't fix that easily. And so I only do 2 lifetime. And a lot of times you get a fair bit of relief, at least partial. It doesn't fix the problem. It's a Band-Aid, but sometimes people get enough relief with the stretches that they're good. They don't have to do anything else. The one thing I warn you about is it's painful. We do a lot of them, so we're very quick, but it is worth it if you're miserable. I don't routinely use orthotics. For me, it's kind of counterintuitive. If the arch is failing and you put an arch support in to push up on that arch, for me, it's counterintuitive. It's very expensive and I don't believe in it. And so I don't recommend somebody pay $400 or $500 for a custom orthotic, or $800, $900 for an orthotic to treat heel pain. And so if all else fails, I stretch the calf. So it's a small procedure. The American Orthopedic Foot and Ankle Society recommends at least 6 months of failed conservative care. So we adhere to that. We try to make sure that we've done everything we can to avoid this. And it takes about 3 to 5 minutes, taking our time. We would make a small incision right where the muscle and tendon meet on the gastrocnemius, and we basically cut across that. And so people's eyes kind of light up when I say that. And really what you have to keep in mind is that these two muscles are connected to each other. And so it doesn't go boing like you think. It stretches to the length of that soleus muscle. So that exam, if you remember me showing you the exam, checking the ankle motion with the knee straight and bent, that exam becomes normal. That, just like my 4-year-old daughter at the time, that exam is normal. And so it stops at that length that it should be, and it fills in with scar tissue in that lengthened position. And so the advantage of this versus releasing the plantar fascia, I just wrote a book chapter on this. Releasing the plantar fascia and this procedure were looked at directly in a level 1 study, compared. There was no comparison. And so releasing that plantar fascia without addressing what causes the plantar fascia to develop, the tightness in the calf, you're just releasing that check rein and you're going to wreak havoc on the foot. And that's what the literature shows. And so it's a small little procedure to stretch the calf, put you in a boot for 2 weeks. You can walk immediately. You leave the boot on for 2 weeks, we see you back. And once the wound is healed, we send you to some therapy and you're done. And so it's pretty straightforward. I think we did a study 6 years ago, probably 70 patients. We had about 96% success, if I remember right. And so it does work. It's not perfect. Unfortunately, nothing in medicine is perfect. We can make no guarantees, but for the amount of risk that it takes, the amount of recovery, if you've lived with it long enough and it's limiting your quality of life and you can't take it anymore, it works very well. So I think we're on to the questions, Heather. Hopefully that was helpful.
Yes. So the first question is, what if I've had my foot fused together already?
For a flat foot, a bunion, it just kind of depends, right? If you've had a fusion for the flat foot, that can become very challenging with the ankle ligaments. There's a ligament on the inside of the ankle called your deltoid ligament that is just a major challenge. We don't have an answer for that. We don't have a perfect answer for that, but that can be a challenging problem. It depends on what's been fused as well. And so if they fused those joints in the back of the foot, but didn't fuse the ones in the front of the foot, that could be a problem. It just kind of depends. It's really hard to say.
And how long is the recovery for bunion surgery?
It pretty much the same as the flat foot. It depends on how good the bone quality is at the time of surgery and what other procedures are done with it. And so, I didn't talk about it, but a lot of times bunions are associated with some pain in the ball of the foot as well. So you get this marble or sensation or bunched up sock underneath your lesser toes. And so sometimes we address that as well. Again, we're trying to balance the weight on the foot. And so depending on how much extra work we do, if we just fix the bunion, a lot of times I'm letting people walk it, on the heel at 2 weeks, but you're still immobilized and protected for 3 months because those bones have to heal. If those bones don't heal, we got to start all over again. And so there's a couple principles with bone healing that you want stability. And if you're walking on it, that could potentially create too much motion and can prevent things from healing.
And when can I drive if it's my right foot?
That's a big problem. So everybody that comes in with a broken ankle on the left side, I tell them they're lucky. If it's the right side, I tell them they're kind of hosed. Pretty much no sooner than 3 months.
Can flat feet cause leg pain?
So potentially, those tendons are attached to muscles that run up the leg. And so it's not uncommon for that to be the case. The other thing I've seen is I wanted to do a study with Dr. Canone, one of my kind of total joint sports medicine partners, about flat feet affecting the knee. And so, I think if the weight is not balanced on the foot, I think it can cause undue stress up the ladder. So potentially, yes.
And I think you answered this already, but how expensive are custom orthotics?
I think it depends on where you go. I honestly don't know what they cost with us, but I know most custom orthotics are, $300 to $500 if I depending on where you go. And I honestly don't even have those specifics.
And can they be worn in more than one pair of shoes?
That is the goal of the orthotic, is that they go from one shoe to the next if we're adjusting the weight appropriately and it's improving your symptoms.
Can I run after surgery for flat feet?
It depends on the type of surgery, the type of bones you have. Again, I think flat feet is a more severe arch collapse, and so I think you've got to look at it from the standpoint where typically, I'm recommending surgery or doing surgery for folks that can't even do activities of daily living. Walking, just getting up and standing on the foot is excruciatingly painful. I think people run into problems if the expectations aren't correct. If you've got a severe flat foot that's painful that needs one of those reconstructions, we're trying to get you back to walking that is tolerable, hopefully pain-free, tolerable at a minimum. But getting you back to running, I'm not sure that I would say, yeah, we're going to get you back to running with this. If we're taking a tendon from somewhere else, we're just trying to make walking tolerable.
Can you talk about the limitations of home calf stretching to completely resolve equinus and foot imbalance?
That's a good question. So interesting, I believe Dr. Samarco in Cincinnati did a study, I don't know how long ago, but he looked at doing this aggressive stretching. And so if you look at that, if you remember that picture, there was probably a 25 to 30 degree difference in the ankle motion with the knee straight and the knee bent in the patient that from Grand Rapids when I was in my fellowship there, that with the blue arrows. And Samarco basically showed that you could only get about 4 degrees of motion with a really aggressive stretching regimen. So you're really not going to correct it on your own, but you don't have to if the pain goes away. And so all we're trying to do is get enough so the pain goes away. If the pain doesn't go away, then that's why we stretch it for you. And let me say this, we're talking about the equinus. So my philosophy is with this, the whole concept of a tight calf muscle is becoming wildly popular in my field of work. And it hasn't always been that way. And I liken it to when I was a resident. And so when somebody would break their ankle or hurt their ankle, we'd have to put them in a splint. We always made sure we put the foot at 90 degrees because the concern was if we didn't, we put the toe pointing down at all, they would have a contracture that we'd have to then operate on. And so if you think about it, looking at my daughter when she was 4 during that, on that picture, she hadn't started school yet. And so hamstrings are a very common problem that everybody has, tight hamstrings, almost everybody has it. And if you think about our lifestyle, really, we have a very sedentary lifestyle where we sit a lot. And so if you sit and shorten those tendons and the muscles, they're going to contract over time. And that's just the way things work. And so, the same thing with a calf. And so like I talked about with shoe wear, everybody thinks it's the pointy shoe that pushes the toe over. I don't think that's the case. If you're wearing a shoe with a heel, you're shortening that muscle and that's going to contract over time. And so I'll look at my dress shoes in the office. They all have a little bit of a heel on them. And so females that wear high heels, you're really shortening that calf tendon. And so I think it does involve the shoe wear, just not to the same extent people think. And so, for me, if any pair of shoes you have, it's pretty much always thicker in the heel. So that's creating that overload to the front of the foot. And that muscle lives in that position that long, it's going to conform to it and it's going to create that problem.
How would you alter flat foot treatment in the case of an accessory navicular bone?
So that's a little bit different. And so if the accessory navicular bone is angry, again, I still will try to, first thing I do, just like we do with kids, and this is a more common problem in pediatrics, where we rest them. So kids will put in casts because they won't wear the boot, but adults I'll put in a boot with a posted orthotic. Again, that accessory navicular is not attached to the tendon, but it can be aggravated from the same mechanism, from that arch trying to fail. And so again, I try to prop the arch up with the insert and I try to rest them in the boot, and therapy and inserts and all that stuff and calf stretches. And if all that fails, it's not the same as a standard flat foot. And so even if you have a flat foot, but your pain is isolated to that extra bone, Sometimes we can just take that extra piece of bone out, and then I stretch the calf at the same time while you're there, and you can walk right away. And so it's a less aggressive surgery, but we've got to be convinced that the pain is at that bone and it's not the tendon itself. And I've done a handful of those here recently, actually. So it's a good question.
I had a bunion bone spur fusion. My big toe was fused together.
That is the other option I talked about, where they can fuse your big toe joint. And the problem is most people don't want their big toe fused. Now, there's certain times when there's a lot of arthritis there. So another analogy I like to use is, if you've got a bunion, if you remember, that joint's not lined up the way it should be. And so I like to tell people, if you have a tire on your car and the tire is not balanced, what happens to the tread? Well, it wears out prematurely. And so a bunion, that joint is not lined up the way it should be. And so it's going to wear out just like anything else would if it's not lined up appropriately. The other analogy is an ACL tear. People that tear their ACL, if they're young and active, what do? Well, not me personally, I don't do it anymore, but my partners that do that stuff, they fix it because it provides stability to the knee. And if that stability is not there, the bones will move too much, it'll wear the cartilage down. So, there are times when absolutely I do a fusion of that joint, but most people want to maintain motion of that joint. So where I fuse it, we'll still maintain that motion. If you've had it fused, that is, if it's healed, your bunion's not going to come back. So you don't have to worry about that.
I have heel pain in both heels. I stretch calves 2 to 3 times a day. What else can I do?
You could try, it depends on the type of stretching. So a lot of people like to stretch both the gastrocnemius and the soleus. I would just focus on the gastrocnemius. You could try a little therapy. We could put you in a boot. You could try a shot. Again, the shot will give you some relief. How long? I don't know. There might be somebody else here that has some experience with that. But it kind of varies. And again, it's kind of limited. For me, it's all about the stretching. If you're doing that, you're doing all the right stuff. You're treating the root cause. The boot will hold you stretched out at 90 degrees. It'll maybe calm things down. But that's kind of my stepwise progression. So, if they do the stretches, it doesn't help, we can try a boot, we could try a shot, we could try some therapy, one of those three.
Can plantar fascia pain be confused with peroneus longus snapping out of its groove, causing pain?
Typically, no. Snapping tendons can be confusing, but not typically. So my 3 main causes for heel pain, and in this order of commonality, plantar fasciitis is by far the most common problem. The next most common, and it is way less common than plantar fasciitis, is tarsal tunnel syndrome, where everybody's heard of carpal tunnel in the hand. Well, it's that nerve that dives down on the bottom of the foot, so that can be pinched and cause some pain. And the third, that is the least common by far, is a heel stress fracture. So those, in my opinion, are the most common causes of heel pain. Snapping of the peroneal tendon typically is going to be caused around the ankle.
What if your bunion doesn't hurt, but your toe is literally crossing over your next toe? It is unsightly and developing a bump on the bottom of my big toe. Surgery recommended?
Not if you can live with it. So those would be the cases where we try one of those toe spacers. Again, if it doesn't hurt, don't have the surgery. I know, people will be told, you better get it fixed or it's going to get worse. It can be fixed at any point. If it doesn't hurt, don't fix it. The other thing I would tell you is, as an orthopedic surgeon, I don't fix cosmetic deformities. I try to treat pain. And so, I can take something that doesn't hurt. If you want it fixed, then I can make it hurt afterwards. And so, that would be a situation where we try a toe spacer. As long as you're finding the shoes that you like, you can wear, I wouldn't have it fixed.
I had lateral ankle ligament reconstruction surgery, gastrocnemius lengthening, and removal of accessory navicular almost 4 months ago. I'm having heel pain. Why could this be?
Interesting. So when we stretch the calf tendon, we do temporarily weaken you. All right. And so a lot of times the heel pain is not from the plantar fascia, but it's over the bone. And until you get all that strength back, sometimes that will cause overload to the heel bone. I basically tell patients, I want you to do 10 single leg toe raises, and 99 times out of 100, once the patient can do that, that heel pain goes away. So and I'm very particular, especially if I do it for plantar fasciitis, I want to make sure that they're not still having plantar fascia pain. And so that's typically what causes that. And so the literature would show that if you have that calf stretch procedure done, it doesn't weaken you indefinitely. It's only a very short-term thing, and it's just a process. You just need to rehab it more.
That was our last question. Does anyone else have any additional questions for Dr. Cheney? Oh, there's another one. You talked about forefoot imbalance, but can you elaborate on what transfer metatarsalgia is, how it presents on the appropriate positioning of the metatarsal head pads?
Oh, wow, that's a very specific question. So again, as the big toe gets tired and that joint gets loose, the big toe is able to elevate, okay? Big toe joint, right? And it's able to actually elevate up, okay? So then the weight shifts over underneath the lesser toe bones. And so that's when you start to feel that marble or that bunched up sock sensation. And so that's metatarsalgia. Now, at the same token, you can also have a neuroma, right? Which is a swollen, angry nerve that lives between those metatarsal bones. And so, but I believe it's still due to the same problem, right? The weight is still shifting over to those lesser toe bones. And so I still treat it the same way. So the first thing I do is, again, I try to treat the weight distribution problem. So I use an insert with a pad, and I actually have metatarsalgia that is rip roaring. And so we basically try to take a pad that sits just behind the heads of these bones, and we try to distribute the weight to a bigger surface area off these small bones. And so whether it's a neuroma or metatarsalgia, and in my opinion, neuromas are way less frequent than metatarsalgia. And so we do the calf stretching, we try to shift weight off those bones that are taking the weight that shouldn't be.
Any additional questions? Thank you, Dr. Cheney.
Thank you very much. I hope it was helpful.
Thank you for participating in tonight's webinar. Our next webinar will be held on April 7th. Dr. Rodney Komisar, orthopedic surgeon, will speak on sports-related knee injuries. Have a great night. Thank you.